Welcome back to Taking Care of My Cancer podcast, episode 87. And I'm super excited to have in the show an amazing speech pathologist and a dear friend who we've been trying to do this together for almost, I don't know how long, a year now since since I started the podcast, but this is Lauren Meffen, and Lauren is a speech language pathologist, a certified lymphedema therapist with a passion for working with voice and swallow disorders. She has remained local here in Gainesville after receiving her education from the University of Florida. Over the years, she has developed a love and a specialization in working with the oncology population. She has advanced training in management of lymphedema of the head and neck, trismus therapy, FES, stroboscopy, and manual therapy techniques. She strongly champions a comprehensive approach towards treating the whole patient with the involvement of a skilled multidisciplinary team. So Lauren, I'm so excited to have you, and thank you so much for being here with me today.
Thank you, Darlie, for having me. And I also consider you a dear friend. We've had many years of being lucky to work together in both the hospital setting and then seeing each other sort of grow in our love for this oncology population. So thank you. I'm very excited to be a part of this.
That's excellent. So you want to tell me about your role or mission and where we're always planning to do this?
Yes. So I was not always planning to do this. I started out as an acute care speech pathologist, and in the hospital setting over the years, you learn where there's a need. And in our community here in Gainesville, there was a need around 7 to 8 years ago, maybe even 10 years ago, that I noticed for the head and neck cancer population. And so I decided, okay, my mission is to change those patients' life in our community. And so my goals initially started out with just the patient. And all I wanted to do was make a difference in the life of a patient who had this diagnosis and who was left with the long-term side effects, typically related to swallowing and radiation. Oftentimes, these patients, 10 years later, 15 years later, we would see them for an aspiration pneumonia, and they did not know what to do from that point forward after discharge. And then slowly over the years, as my training developed and I learned from some wonderful mentors, and we've created this beautiful network in Gainesville, I decided, I think I can make a difference in the life of therapists as well. So my second mission now in this world is any speech pathologist, physical therapist, occupational therapist who has decided they want to change the life of a patient with head and neck cancer, I try to be a part of that if they need some support. So I have two goals, and those are them.
That's awesome. That's awesome. So tell me, what are you doing about doing this to develop this therapist to be better on how they treat head and neck? What is it that you're doing right now?
So there's two ways that I do it. I'm a part of the community groups for speech pathologists. There is an awesome Facebook group that's called the HNC SLP. And so that Facebook group, in there, I try to be an active part of that. Additionally, I play a role in trismus intervention, a specific side effect that sometimes happens to our head and neck cancer patients. And I love to play a role in the National Lymphedema Network for the past couple of years, as they need a little bit of backup time from time to time for head and neck cancer. So I have created just sort of this small little network of therapists who love this population.
That's awesome. So, so I remember, Lauren, back then, because I do some acute care still in North Florida, and I remember as you being so passionate from the beginning about this, and then you knew I was working with oncology, and so our conversations, that was so much fun every time we saw each other at North Florida, like about head and neck cancer, and then you were teaching me stuff from like the speech pathology standpoint. But then you were like really questioning, like, well, what should we do with this patient? And if this patient has lymphedema, what should we do with this patient? And then all of a sudden, boom, I see you like, oh, I'm not working there any longer. I'm going to start to really work in outpatient. helping this. And then I've been trying to recruit you to come and work here at UF forever because you're just amazing. But I'm so glad that you open your own practice
Oh,
and you know that we refer you a lot of patients because I think that it's beyond just being a speech pathologist, right? So this is just a piece of
yes,
it, but you really have to be having all this comprehensive knowledge and different tools to be able to treat these patients the better way possible. And it's not that many speech therapists that go into the adventure or become a certified lymphedema therapist. And I apply you for that because it's hard.
thank
And it's
you.
hard when you are in your career. It's a lot of things that you did not learn because that's not what the speech pathologists learn. So that was amazing that you were able to do that. And again, it's more and more to come, hopefully, on the, on the head and neck and lymphedema, more, hopefully more research, and maybe it's not as much
Yes.
research than we have for upper extremity with breast cancer and things like that. But hopefully we'll continue working towards getting better and better, and really how can we prevent and how we can really help these patients early on so they don't have so much trouble later.
Yes. Yeah, I think these patients do have a lot of trouble, but I think the key is, like you shared, there is a lot of research that is being done right now. And hopefully over the next 5 to 10 years, we as therapists will be able to apply some of the exercise science that's already in the breast or in other parts of the extremities to the head and neck.
Mhm.
So I'm excited to see what's to come as well.
Yep, absolutely. So what good resources would you advise patients to look into to educate themselves?
So I think the first thing I always encourage my patients is I want their resource to be us. Whoever is the speech pathologist, the physical therapist, the occupational therapist, I want them to ask us first. And then what I have learned is that each of these patients in the head and neck cancer world are really an individualized treatment based on their primary site, based on other coexisting morbidities, also based on if they've had surgery or not. So first, I want them to really ask us the questions. And then additionally, what I have found is that between the multidisciplinary team, we can often answer those questions for them. So I encourage them to start with us. I do find, and I always joke around with my patients that, Dr. Google only knows so much. So don't ask Dr. Google, just encourage us. How can we help you? If we don't know the answer, we have direct connections with your physicians and we can get you answers.
Okay, great. If it's anything in particular, like if you feel like, it's any like websites that you will encourage them to go for support groups or look into farther into it, is anything specific that would you advise them?
Yes, so there are two websites that I like to refer them to on Facebook. There is a laryngectomy support group, and there's a head and neck cancer survivor support group. Both of those groups I have found have wonderful resources and a wonderful community for the Larry Speak Easy in our laryngectomy population. There's some amazing physicians in there. There's speech pathologists in there. There's patients in there. Those are two groups I think are awesome.
Right.
Absolutely awesome.
Would you give us 3 valuable tips that can help patients with head and neck cancer?
My first one is always have a partner in crime. I'm not a believer in going through this by yourself. I have found that the patients who do the most successful are those who have a support group. It doesn't need to be one person, it can be many. But when you're diagnosed with head and neck cancer, you're referred to an ear, nose, and throat, or radiation on speech therapist, a registered dietitian. It's a lot. There's a lot of people who you were referred to. And so I've found that a second set of ears always helps. That second set of ears will always help. The second thing I love to encourage my patients is stay positive and really protect that inner spirit. Don't forget what makes you shine every day. If it's your dog, love your dog before you walk out the door. Whatever makes your heart the happiest on your way to treatment, after treatment, don't forget that, because this is a very hard treatment to go through. So that's my second advice that I always like to find. And I do that motivational interviewing with my patients. I learn that about them. And then the third thing that I always say is show up every day for your treatment that you are scheduled and ask questions. No question goes unasked. It doesn't matter if you ask 100 questions, whatever you want to know about your body, about the side effects you're experiencing, we're here. So just ask it. Those are my 3 words that I was like, okay, here's my thoughts to help get you through this treatment in the best way possible.
That's awesome. I like that. I love what you just say about, love what you love the most prior and after treatment. I think that's a great idea. I may start to implement that here.
Yeah.
Definitely. It's like, it's funny because that's what I do as I'm leaving home and as I coming home, right? That's what we do every day. So
Absolutely.
yeah, that's very good. What would be the greatest tool that you will share with other speech pathologists that can help them to implement their treatments with patients that has been diagnosed with head and neck cancer?
The best trick that I could give, and the thing that I think is one of the most challenging long-term side effects, is treating radiation-induced trismus. And so one of the most valuable tips that I will give to other speech pathologists, and one of the things that I ensure all my patients know how to do who have a diagnosis within the oral cavity, so somebody who's had resections or oral cancer, are at a higher risk of developing this trismus or an oropharyngeal tumor in which the same side or ipsilateral pterygoid and masseter are being treated with radiation. I will teach them the 3-finger rule. So what you do is you take your middle 3 fingers, put them together, stick them in between your upper and lower teeth, and ensure that your patient can open the oral cavity. That's considered quote unquote within normal limits. And so the tricks are, if your patient can self-monitor that, then they can know and understand when there's a change, because maybe their 3 fingers over the years goes to 2 fingers, and they can seek help sooner rather than later. We understand enough about radiation fibrosis syndrome and that the side effects do change. That trismus, we know the high risks. We know those patients who receive over that 60 grays of radiation to the oral cavity, those patients are at a higher risk. So we can really monitor those patients much closer. We can't prevent it. And so the key is, if there's a change, if the 3 fingers goes to 2.5 fingers, if the 3 fingers goes to 2 fingers, you talk to your therapist and your physician right away so that you can get those daily stretches for active range of motion and maintaining your oral opening. That's my biggest tool. We know that 1 millimeter a year will potentially decline in those high-risk patients. That's an expectation. So education's everything. It's everything for us, for these patients to have that long-term success.
Yeah, that's very well said. And as well, not that many speech therapists feel comfortable working with TMJ, which again,
I
the
agree.
TMJ, it is, like I said, that's one of my specialties. And then 50% of the jaw is coming from upper cervical spine. So you need to be comfortable doing joint mobilization and working on the neck as you're working with the joints. So for the audience out there who are therapists, speech or OTs or PTs, again, if you come across a patient like that and ooh, I can only have these tools to help them, then refer out, right? So just go ahead and work
Absolutely.
with the physical therapist, and then kind of like, hey, I noticed this, I can only by my scope do so much. Would you just go ahead and make sure that these patients get joint mobilization, intraoral joint mobilization, and so forth, to try to kind of get them where they need to be at? So that's very well said.
I think you hit the nail on the head. Then we do have to refer out. It has to be collaborative. Speech pathologists have great training if they've taken the training in the muscles of the mouth. We don't know much about the joints. We don't know much about upper cervical. This is a PT and a speech pathologist, or a PT and an OT referral. So it is very important to be comfortable knowing who in your community are you going to refer to when these issues arise. That's all.
Yeah.
And your
Yeah,
patients will be happy.
exactly. Exactly. What is a common question that you find oncology patients have? And will you share some of that information with us?
Yeah, so my most asked question would, of course, be by the patient who has been through treatment, they have completed treatment, they are now 3 months post-treatment, and they ended up with a feeding tube at some point. The most common question in my world is, when will I get rid of this feeding tube? And that is very specific to the head and neck cancer diagnosis. We do believe in trying to have our patients continuing to eat and drink, and we place a feeding tube as needed in most of our cases. But when a feeding tube is needed, we find that that is a hopefully short-term solution to maintain their nutrition, their hydration, decrease their risk of aspiration. And the way that I look and I approach that question for my patient is, first of all, I'm always positive. The feeding tube will go away. It's just a short-term solution. Mm-hmm. And then second of all, we start to set those sequence of steps of how are we going to wean that feeding tube? What are you able to take safely by mouth? And then what can we do to sort of look at dropping those cans? I'm always doing that in conjunction with the registered dietitian so that they can monitor for any other side effects that are related to things that I don't understand as a speech therapist, the kidney, the liver, all sorts of things that are needed from a nutritional standpoint. So again, it's just a team approach.
Very good. How did you do? I have come across patients who they don't want to get rid of the feeding tube. You have these patients, yes, in radiation. Oh no, they have surgery, they have the feeding tube, and they're just like, no, actually, this is easy. I really don't have to bother, and I really don't have to swallow, and so I mean, how do you approach those patients about like, no, this is not a good thing to have the rest of your life? I can only tell them from the general standpoint. It's like, this is the risk for infection, you're pulling this, and of course, you're not using your muscles and your throat, and you're not opening your mouth to eat. So you're going to just put yourself into develop trismus, having, fibrosis on your throat, because then you won't swallow in anything and you're having all this radiation. But from the speech therapy standpoint, like, what else would you tell them?
I would say the exact things that you said. So I'm a big believer in, well, let's walk through what this looks like if you keep this feeding tube for the rest of your life. Every 3 to 6 months, the feeding tube needs to be changed. It's going to be clogged. It's going to be regurgitating materials from your stomach. You're going to have increased nausea, potentially increased vomiting. Yes, it's easier to use the feeding tube. However, in 2 years, you probably aren't going to want to do that. But in 2 years, if you don't use your muscles and only use the feeding tube, now you're in a bind because the swallowing muscles have atrophied. Your posture is terrible, right? So their shoulders are forward. They're in that kyphotic-like posture. And you haven't utilized any of the muscles for your airway protection. So now we've sort of snowballed this effect. So in my world, as a speech therapist, I take the swallowing rehabilitation piece very seriously. You're here to see me to rehabilitate the swallow. And if you're not ready to address that, then you're not ready for therapy. But I need you to know that this is my mission in your life, is to ensure that you don't have this feeding tube, or that we are on the least restrictive diet. And you're right, these patients don't have taste. They're not motivated to get rid of the feeding tube sometimes. Mm-hmm. You really have to go through those motivational interviewings, like, well, what food does work for you? And sometimes they say nothing works. It's like, okay, well, what drinks work for you? And you start at what they can drink. And you just start and meet them where they're at. You increase your patience as a therapist, and then you go from there. That's the goal.
Okay, great. That's a very good tip. That throws me into, let's go into the speech part of it. So something that I really love about you was, I remember having these patients with the hemiglossectomies. And for the audience there, that means that part of your tongue is being taken out and hopefully replaced with a flap. So this tongue has to relearn how to move again, like any other part of the body. And we were, I'm a manual therapist, so very hands-on. And then it's like, okay, if this is another muscle, like, who's supposed to be responsible to be stretching and working on this soft tissue in the tongue and stretching the tongue and all that. And then so we were like, well, that's kind of a speech therapy because it's the tongue and has related to speech. And then I was just talking to you back then when you start doing this. It's like, well, no, really, we don't get trained in the school to do this. It's like, what? What do you mean you don't get trained in the school to do this? Because you guys supposed to be the tongue
On the
is part
tongue.
of talking, and then it's
Yeah.
that's something that you learn after work, and then we use that, and then you show me some few techniques to get those patients tongue stretched. So all of us apply here and at least teach them, because unfortunately, really very few speech pathologists do that. So it's like, wow, like, so I usually tell patients, if they go to see you, I know they're going to get that from you, but if they're going to see somebody else, I tell them, you need to ask them. And if they don't know how to do this, tell them to find out, or you go find somebody who knows, because that's going to be super important. So you want to tell us a little bit about that?
Yeah, so for me, working with the tongue and range of motion is everything. So for your hemiglossectomies or your partial glossectomy patients where part of the tongue or half of the tongue is removed, if you can understand from your surgical standpoint where the surgeon has placed that tongue in the mouth, you can understand the timing of the flap. You can achieve orders for manual oral work inside the mouth from your surgeon and clearance. We know that we have to move things in order for things to improve. And so for these patients, when the tongue doesn't move, the swallow is impacted and the speech is impacted. One of their biggest challenges is that they have trouble communicating with the people they love. They have trouble communicating with work. And so we go through, in our clinic, I will go through a series of trying to determine what is their tongue doing when they come to me, and what are some realistic goals that I can teach them to do themselves with touching their tongue, stretching their tongue, knowing which tissue is movable, which tissue is surgically adhered to the floor of the mouth, and then going through a series of daily home exercises that are sustainable for those patients. So I am a big believer of working inside the mouth. I have found that many people are not comfortable inside the mouth. When I first started it, I wasn't comfortable with it either. The more you do it, the better you get at it, the more you understand the normals, and the more you're comfortable when there's atypicals or anormal, these patients have changes. So I say the key is everything. If you don't work in the mouth yet and you're a therapist, at every appointment, you are inspecting the inside of the mouth. You are learning how to touch the tongue, the sides of the tongue, the insides of the cheeks, the lips. You're learning all those normals, even the patients who haven't been surgically altered. And then you have these patients come to you who've been surgically altered, and you have a comparison. So I think it's a great starting point. But you have to touch the mouth and the tongue. And if you don't know, then get with your physical therapist who works inside the mouth a lot, like you said, with the TMJs and things, and can start to kind of lead you down that path.
And then something that you actually taught me as well is, you improve the mobility of the tongue towards whatever direction needs to go, and then you usually follow that with your phonemas, right? So
Yes, absolutely. You do. You always want to improve that mobility of the tongue in the direction, and then you want to learn where's the compensatory strategies necessary, right? So if they've had the right hemiglossectomy and a right neck dissection and right surgical sites and right radiation, then you're determining from a swallow and a safety standpoint, what's the safest way for that patient to swallow? Is a right head turn helpful? Is placement of the bolus helpful? Where do you put the spoon when it goes in your mouth? Can they use a straw? Can they close their lips? What if they can't? Is there a cup that you could change to? Do you need to modify the consistency that goes in the mouth or the place where it goes in the mouth because the tongue doesn't retract, right? So you're always troubleshooting. You're just always trying to understand that. But if you, the therapist, know how the tongue, the lips, and the jaw move together in your patient, then you can better offer them strategies and solutions. You can't always fix it, but you can give them strategies.
yeah, absolutely. Um, what book recommendations do you have for the audience, and why?
Yeah, the one that I love the most is a recommendation for patients and caregivers. It's called Meeting the Challenges of Oral and Head and Neck Cancer. It's a guide for survivors and caregivers. And I have found that this particular book goes through the side effects. It goes through some of the many questions that these patients will have, and also goes through some guidelines for caregivers. I think that the spouses of these patients also have some serious challenges. The spouses of these patients go through some trauma themselves. They're watching their loved one really kind of be knocked down. And so support for the spouse, support for the child, whoever is that network who's going to help get you through your treatment, those are needed. So that's one of my favorite books.
That's excellent. That's very good. And I'll try to put that on the show notes so people can access to that. Any podcast recommendations?
Say that again, Darlie. I'm sorry.
No, that's okay. Any podcast recommendations?
For podcast, yes. Okay, so
Okay.
my podcast recommendations are specific to private practice owners.
Uh-huh.
And so what I have found is that many of us as therapists who love this oncology population, sometimes we will want to open up our own practice. There are two podcasts I'm a big fan of. Strata PT, STRATAPT. That is a wonderful podcast for private practice owners and learning to troubleshoot some of the challenges. And the second one I'm a huge fan of is Anthony Maritato and the Medicare billing. And that one is particularly a YouTube channel. But what I have learned is when you work with this population, finances are an issue, insurance changes are huge. You need to be able to understand if you're going to run your own private practice, especially geared towards the oncology population. What am I willing to accept for payment? What am I charging? How do I obtain authorization? And how much headache is it worth to work for insurance companies? So I think as a therapist, we mean well starting off, but there's a lot of hurdles we have to learn to jump over. And so from a therapist standpoint, those are two that I've learned a ton from.
Okay, excellent. Anything for the patient standpoint? Just specific to head and neck?
That was a hard one. And I thought of that. I think that the YouTube channel that involves Kelly Strum, your podcast, I will refer them to. I think that it's valuable for patients to know that there's other patients who have gone through this. And I love listening to your episodes where you actually interview the patients,
Yes.
right? Because it's nice to have that perspective.
Yes.
It's nice to know you're not alone. So
Yeah.
that's a huge deal.
Yeah, perfect, perfect. How can people find you?
There's two ways. So if you're a patient who wants brick and mortar help, meaning coming to the clinic near Florida, our website, www.gainesvilleslp.com, is me. And we also offer virtual appointments for patients who do not live near Florida. And then if you're a therapist who wants on-site trainings or to learn more about the second would be headandneckrehab.com. And so those are the two ways that I will encourage people to find me.
Okay, excellent. And like I said, I will put that on the show notes as well so people can find you.
Okay.
How can the audience find a speech pathologist to help them with their needs during and after treatments?
I love this question, Darlie, because there is not an ideal way, if you are a patient diagnosed with head and neck cancer, to find a therapist who specifically works with this diagnosis. About 3 months ago, I began a personal project of creating a directory for head and neck cancer therapists. I'm in the works on it. If you are a laryngectomy patient, Larry's Speakeasy does have an awesome directory for providers. Otherwise, to be continued for the year to come.
Okay, that's awesome. That's great that you took that initiative. Yes, we kind of start as well here in the clinic, a little directory as well for PTs that we can refer patients that have that more, with head and neck. It's not just about lymphedema, right? This is just a piece of it. It is about the jaw. It is about the fascia. It is about the shoulder because with the spinal accessory nerve injuries, posture, all these things that can happen, mobilization to the hyoid and all these other things that are going on with them. It's really hard to find somebody who has all the training to be able to help you with all of it. So sometimes, I have patients coming from Tallahassee and I'm like, you go find any therapist can work with your neck and your shoulder. That's pretty much any therapist can do, any PT can do. But you need to find out somebody who is specialized in lymphedema. However, not everybody who specializes in lymphedema feels comfortable with head and neck. So many times you can be a CLT
Right.
and you only do arms or legs and you don't do any head and neck. And then not everybody who does a lymphedema therapy head and neck feels comfortable working with the jaw. So you need to find somebody who specializes in TMJ. So really it's hard to have all these
That's
skills
hard.
required to have these patients going. So we try to do the same thing. Let's try to find therapists that feel comfortable, that we know at least we start here in Gainesville, which is not really that many besides us, but
Oh.
well, but then start in Florida, like what else can we start refer? I usually tell patients if you are anywhere else and you find somebody that is doing similar stuff that what you experienced when you were here, please let me know so we know we can refer out to them.
Yeah.
I'm so glad you're doing that, and I would love to have that directory when you're done with it. So that would be good. We can really I have no idea about speech pathology. Like, in town, I know I referred to you when they cannot be seen here. But that's really good for me to know that you're doing that. Excellent. What is
Awesome.
one question that you wish I would have asked you and you have answered before I let you go?
Okay, so I would say, what advice do you give to the beginning clinician, to the clinician who doesn't yet work with the head and neck cancer patient, but they want to learn how to do this? And my answer is allow yourself grace. This is a challenging population with many side effects. And find a beautiful mentor who you can ask a ton of questions to, stay engaged, and listen to your patients. So, for the clinician, my question and advice is just get started. If you're interested in this population, we need more of you. We need more people who are passionate about helping the patient who's been through head and neck cancer. They often do have lifelong side effects, as you were sharing from a physical therapy standpoint with the spinal accessory, as I share from a dysphagia standpoint. And then for the patient, the question that I would vote is, finding additional resources can be challenging. And so I think when they need something, asking us as therapists and allowing us the opportunity to research for them, I always encourage them. So I might say, I don't know the answer, but I'm going to see if I can find out, so those would be my final thoughts.
That's awesome. So that has been super awesome. Lauren, thank you again for being part of this show. I really appreciate it, and I'm sure the audience will love to hear from you.
Thank you so much, Darlie. It was awesome to be a part of this.
All right, you have a great rest of the afternoon.
You too.
Bye.